Thanks very much. So, what we'd like to do today is talk about COVID. And so first, though, I want to just introduce myself. Um, I'm an infectious disease physician, and this is a slide that shows some education in 1986. You can see Dr. Fauci in the foreground, and in the center of your picture, next to the television set, I'm standing there. I did my infectious disease training at NIH. I was there for 3 years with Dr. Fauci. Um, Used to be an ordeal to try to explain non-medical people what infectious disease doctors are and what they do, and that's much better known today. We're trained in diagnosis and management of infectious disease, infection prevention, and epidemiology, and that's our background. I am part of a large group, ID Care. We're 90 clinicians in New Jersey, and we go to about 150 facilities, including hospitals, nursing homes, subacute facilities, and rehab centers. And we also have several offices scattered throughout the state. The next thing I want to do is thank all of you. I think that you are some of the least heralded heroes of the care of patients with COVID. If you hadn't done what you did in New Jersey in terms of manage in place, our hospitals would have been overwhelmed in April and May, and I think we would have had a much greater catastrophe than what we had to deal with. So thank all of you, and I hope that story gets better told in the future. So let's talk a little bit about the goals of our talk. We want to review a history of pandemics and get a better understanding of that. Talk about the epidemiology of them. Talk about some scientific data and background about SARS-2 or COVID-19. And then talk a little bit about the future and what to anticipate in the next couple of months and year. You can raise your hand and ask questions as we go along. We'll try to answer those questions as we go through the set of slides. So probably what we should first begin with is understanding a definition of what a pandemic is. A pandemic is an epidemic that occurs on a scale that crosses international boundaries and usually affecting people on a worldwide scale. It really doesn't require the WHO to declare a pandemic occurs. A pandemic has its own schedule and plan, but the WHO did declare a pandemic in January. Okay, so let's just go over some historical things. The first report of plague was in Athens in 430 to 426 BC. That was probably typhoid fever, and a quarter of the population of Athens perished from it. And then some subsequent historical plagues are listed there. Antonine plague and the plague of Cyprian were probably plagues of measles or smallpox. The plague of Justinian, 541 to 750 AD, was the first bubonic plague, and that cycled through the world over the course of decades and centuries. And the last major plague was the third plague pandemic in 1855, which involved the United States, particularly in San Francisco. In 1918, we had the first flu pandemic. 500 million people were infected, and 20 to 100 million people died. In 25 weeks, more people died from that flu than people who died from HIV and AIDS in 25 years. So these have been devastating conditions that have occurred. We're not the first ones to need a mask. This is a slide that shows the hoods that were worn in the 16th century for plague. You can see that they're full head coverings with goggles, and in that long cone, herbs and different remedies were placed to, quote, purify the air that was being breathed in. But masks are not a new thing with outbreaks of disease like this. U.S. pandemics have been mostly in the 20th century. We talked a little bit already about the 1918 influenza pandemic, and that was also frequently referred to as the Spanish flu, and it had multiple cycles. There was a pandemic in 1957-58, and that was when the influenza virus changed its markers, H2N2. There was another pandemic in 1968, H3N2, another change. And there was a pandemic in 2009, H1N1, which fortunately was not very life-threatening and didn't have a high mortality. It wasn't really well managed from an epidemiologic standpoint. There was a lot of disease spread, but fortunately it was a mild illness, so there wasn't the devastation that we're seeing today. Many of you may remember in 1976, there was a concern about a swine flu outbreak. And here's a picture of President Gerald Ford getting his swine flu shot. There was a program to vaccinate 40 million people were vaccinated in that year, and it was curtailed when it was noticed that there was a significant number of cases of Guillain-Barré associated with the vaccination. So unfortunately, the cure was worse than the disease, and that program was abruptly halted when that became an issue. That was not a pandemic, that was just an outbreak in the United States. So in our current state, mostly we're dealing with viruses. And what are viruses about? They're not independent living organisms. They need to find a suitable host cell. They need to replicate and they spread. And that's all they're about. In the world, there are 10 nonillion viruses, 10 to the 31st power, but there's only 219 virus species that are able to affect humans. But we're discovering new ones every year. Human coronaviruses, which COVID-19 is in that family. There's 7 of them. You can see that they're just the first 4, which have been long-standing, have been present for some time now, and those 4 all cause the common cold. More recently, they've been identified in a less different kind of nomenclature. We have Middle Eastern Respiratory Syndrome with coronavirus, and then SARS-CoV and SARS-CoV-2. So let's talk a little bit more about that. As I just mentioned, the first 4 there have been causing infections in people throughout the world for some time now, and most of those are just minor flus. MERS, SARS, and SARS-2 have more recently evolved. They moved from infecting animals to becoming new human coronaviruses. This is a micrograph of the coronavirus. Corona is a Latin term for crown, and you can see that the concept of this is the spikes around the surface of it simulate a crown, and that's how these viruses gain their name. Here's a more easy to look at schematic, which shows the spike proteins, purple there, and then the different elements of it, and the coiled structure there being the RNA wrapped in protein. And that's all these viruses are about. They use their spike protein to attach to receptors in your body, in your cells, and gain entry, and then use your cells' mechanisms to make themselves and spread. Okay. We think that most of these viruses really began in bats, and SARS-CoV-2, which is the name of the virus. COVID-19 is the illness. SARS-CoV-2 is the name of the virus. It's similar to the SARS-related viruses that have been previously isolated in bats, especially horseshoe bats, and is believed that it's a bat virus mutated to the point where it could infect humans. And this is a horseshoe bat. You can see the just under the nose, it has the appearance of a horseshoe, and that's how it gains its name. Scientists suspect that the bat virus mutated to become able to infect an intermediate host, such as a civet or a pangolin, before mutating again and being able to infect humans in a process that's called spillover. Civets are cat-like animals. that cannot be brought to the United States, and they're a delicacy that's enjoyed in other parts of the world, particularly Asia. This is a schematic that looks at these three more recent coronaviruses and the intermediate hosts that they've passed through and how they've been transmitted. MERS is mainly the vector to humans was camels. For SARS-1, civet cat, and we're not sure yet about SARS-2, maybe a pangolin. Pangolin is a mammal with like an anteater, and it has scales that are thought to have medical properties, and that they're captured and used for medicinal purposes and folk remedies. Okay, so after human infection, the virus is free to replicate and infect others through coughing, sneezing, and other contact. This is the concept of social distancing. As you know, we may want to keep people 5 feet away or 6 feet away, 2 meters. And I'm going to go into more details, but I see that we have some questions. Michelle?
I don't have anything in the chat box yet. Do you have anything, Tekla?
I don't see any hands raised yet, no.
Okay, I misread that then. Okay, so let's talk a little more about the concept of social distancing. For the most part, when we're talking about social distancing, our concern is how the virus is spread through droplets. And that usually requires being close enough to somebody for them to spit on you and normal talk. So, the risk and the concept of 6 feet or 2 meters is really related to quiet breathing and being next to each other, not even necessarily talking. But, I think you can think about the concept of the more active your breathing is, the further away you need to be from somebody. So that quietly sitting there not talking is safer than talking. And as we move up a scale, then we would think about shouting, cheering, yelling, versus coughing, versus sneezing, versus singing, which is probably the most effective way to transmit the virus and spread it to other people. So let's talk a little bit about the timeline. We're still covering the past. China first reported a cluster of cases in December of 2019. And they identified the virus a week or two after that. And the first case in the United States was seen on or about January 21st in Washington State. Shortly after that, China restricted its travel out of the Wuhan area, a city of 11 million people, and who declared a public health emergency at the end of January. The United States followed up on that the following day. The first case of community spread in the United States was first identified February 25th. The first day was a few days later. And the first case in New Jersey occurred March 4th. Okay, so that's the first segment of our talk. I just want to stop and take a breather. Are there any questions or concerns or any amplifications we need to make about what we've covered so far?
We do have, someone raised their hand and then they put it down.
Nothing in the chat room yet.
Okay. Well, why don't we try to move ourselves into sort of COVID present and what all of you have lived through. Okay, we really have had the perfect storm. SARS-2 is a novel virus and no previous exposure, so everyone was susceptible. It's easily transmitted because of the respiratory route, and it's a relatively low mortality in terms of viruses and outbreaks. And it's only relatively low in comparison to something like Ebola. Ebola virus has had some very devastating outbreaks, but it's very lethal, so that the hosts die and they're not able to pass it. And the challenge with a virus like SARS-2 is that because people can be so mildly ill and transmit it, it can be very easily transmitted without our awareness of that. So how big a problem is COVID-19? As we mentioned, the Spanish flu, 1918, there were over 500,000 deaths in the United States, and somewhere between 50 to 100 million people died worldwide. If you look at the flu for this season, our estimate of how many people will succumb to it is about 62,000. And as you know, we've already had 225,000 people die from COVID. And if you look back at the bubonic plague, the Black Plague in the 14th century, 50 million people died, or 60% of the population passed away. What is COVID? Okay, the MMWR, the journal from CDC, has listed these symptoms. Again, about half the patients don't have symptoms, but you can see that symptoms include cough, fever, muscle aches, headaches, shortness of breath, sore throat, diarrhea in 20%, loss of taste and smell as a heralding symptom. And these are all the symptoms that we usually typically think of as the flu.
Dr. McManus?
Yeah.
We have a question from Steve, who was wondering if there was a way to measure how contagious this disease is compared to other diseases.
I'm going to come to that in a couple of slides, so that's a good question. And so if you could just hold that in mind, and we'll talk that in more detail. But this next slide I show you here now is a slide that I'm trying to help you understand how the bimodal presentation of this illness occurs. Usually the incubation period for the virus is 2 to 14 days. So from the time you get exposed to somebody, the earliest someone is going to have symptoms is about 2 days, and the latest is 14 days. And that's why we have a 14-day isolation period or quarantine period when somebody's had an exposure. And the illness is bimodal, means it has 2 phases. The first part of the illness is a viral response, the virus itself making you sick. And you can see clinical symptoms are cough, diarrhea, headache, just the simple symptoms that you would have from the flu. Laboratory-wise, the lymphocytes are low. There's coagulation, things that might change, and some other parameters we use to measure inflammation are starting to rev up. And so the virus is replicating and spreading itself through your body. And then there's a second phase that then occurs, which is a hyperinflammatory phase, or what's been termed the cytokine storm or bradykinin storm. And this is your immune response to fight off the virus. And this is the part of the illness that really is the most devastating and life-threatening. And this is what has led to the respiratory illnesses and respiratory failure and need to be on a ventilator, that part of the illness. And so you can see that that progression usually occurs over the course of about 2 weeks. So when someone gets exposed to the virus, so for example, if you're being screened and you got exposed and you test positive, the real critical period is about 7 days after your first symptoms, because that's when the cytokine storm is at the highest likelihood of occurring. And we're going to come and talk a little later about treatments, but there's different treatments that work best. One of the challenges in terms of dealing and managing this disease is most of the therapies that we'd like to use, like remdesivir, which is the antiviral agent, and some of the monoclonal antibodies or convalescent serum, they work best before your immune system has had a chance to act in the early part of the infection. Unfortunately, most patients are not coming to attention during that time of the illness. They're more likely coming to attention later in the illness. And the other confounding factor is we do not know who's going to go into a highly inflammatory second part of the illness. 85% of adults do not get hospitalized and are well without any interventions. So how to identify that other 15% who are more critically ill, who may progress, is a critical factor. When the president was ill, he was in the early infection, the viral response phase. And by the reports I've read, He was treated with remdesivir and one of the monoclonal antibodies. Chris Christie might have been a little bit further along in the illness, but he also is treated with the same medications. But that is some of the challenges, is trying to identify who has the illness and then who's going to get much sicker. Testing is really what we use to identify the disease. And this slide shows you how good PCR testing is versus antibody testing. And this is an early study. You can see dated in March. And sometimes we get lost with how good the virus detection is. This is an early study. We think that probably PCR testing is probably in the 90% effective in identifying cases. Patients usually stay positive for, on average, 17 to 21 days. But we've all had experiences in our nursing homes, because we're testing so many patients, that patients can be positive 3 or 4 months later by PCR. Okay. And so it's not really the gold standard. The gold standard would be culturing for the virus, but we don't have that technology available. Also on this slide, it doesn't show the antigen testing. Antigen testing is probably the most effective way of identifying who's actually contagious. Okay, it's what most of the sports teams are using to do their screening, to know if everyone is safe. And it's a test that is very dependent, though, on how likely your test subject is to have the disease. When you're testing people in the setting of an outbreak, the positive tests are very reliable. Unfortunately, when you're testing people when there's not a lot of disease present, you have the risk of false positives, which sometimes will overcall the disease. But that's also probably safer for the community. This is a slide I just want to show you some data that's been reported on other coronaviruses on how long antibody lasts. Okay, you can see that SARS-1 lasts about 24 months. MERS, which is one of the other severe illnesses, lasts almost 3 years. The other 4 COVID viruses, coronaviruses that have been described, have immunity that lasts for about 6 months. Down on our lower panel, you can see that flu and influenza last about 6 months. And that's why you need a flu shot every year. And that's also why you want to be careful not to get your immunization too early in the season, because it may wear off by the end of the season. And then you can see that measles virus there, the immunity is lifelong. Okay, so let's get back into epidemiology and worldwide presence of the disease. In the world, there's been about 42.5 million cases reported and 1.1 million deaths. So that's showing a mortality of 2% of patients who are diagnosed. The type 5 countries for number of cases leads off with the United States, 8.5 million. India, with a much larger population, has 7.9 million cases. Brazil is 3rd, Russia is 4th. And China is now 53rd, reporting only 92,000 cases. I'm not sure if that's a valid measure of the number of cases they have, but that's what's being reported today. This is a slide that shows first day that the states officially had 10 cases. Okay, California at the top, New Jersey listed 3rd. You can see that they're all pretty close, all in the month of March, tracking down there. Now, this is the day that we first officially knew there had cases. This slide shows you the likelihood of a single case within a single day with at least 10 locally transmitted cases, based on some analysis of the presence of the disease. And you can see that even California, for about a month, there were probably presence of the virus in the community before we became aware of it. And part of the challenge of all of this is because there are so many people who have no symptoms who can then spread the disease in the community. Okay, so let's talk a little bit about the states. California is the leading state right now, 905,000. Texas is rapidly climbing at 882,000. Florida has 779,000, and New York has 501,000. New Jersey is now 10th with 228,000. And then if you're looking at mortality, New York has had the most deaths, 33,000. Texas, 17,000. And then California is tied with Texas at 17,000. And Florida and New Jersey are both third with 16,000. However, New Jersey has probably the highest mortality, because you can see that all those states are above us on the listing for cases. And we have about, the mortality in the United States is probably running around 2.5% on reported cases. New Jersey is running about 7.5%. Much of this, I think, is because we had the outbreak so early, and a lot of patients were seen in the hospital and sent home without testing because we didn't have enough tests, and also because we had a very large nursing home outbreak throughout the state that represented about half of all those deaths. Most of the states that were in the early part of this curve had a significant number of deaths in their nursing homes, but as a percentage, New Jersey has had the highest. Now this slide shows daily COVID-19 cases, 7-day average for the whole United States. And you can see that it looks like there's three curves. There's a curve there in April, a curve there in midsummer, and now a curve that's developing now. This is not really three waves. This is really one wave that's very broad. The April curve there is basically New York, New Jersey, and Washington State. And then the July-August curve is really that first wave spreading into the rest of the country. So that part is Florida, Texas, California, and southern states. And now you can see that we have a significant increase in cases in October. Those cases are as the virus has spread through other parts of the country. Some of it's related to return to school. Some of it's related to the holidays and people coming together for the holidays around Labor Day. And the other part of it is that, and this is probably not talked about enough, some of it is because it's just gotten cold and people are inside a lot more. And respiratory viruses spread more when people are inside more. Some people were perplexed with why does Wisconsin and Minnesota have such significant outbreak of cases in the last 4 weeks. They've gotten cold. Everybody's inside. And this is the epidemiologic curve in New Jersey. This is showing actually hospital statistics, patients in the hospital. And you can see that we had 8,000 to 9,000 cases of patients in the hospital early, and about 2,000 of them were on ventilators at the worst. It's very interesting, and we'll talk more about this later, that now we've had a bump up of cases, but only about 10% of the patients are on ventilators. So we went from 1 out of 4, 1 out of 3, 1 out of 4 patients being on a ventilator to now 1 out of 10. Why is that? Probably because the patients that are now ill are younger. And this is just a blow up trying to demonstrate that we've had a ramp up from our nadir, which was in August, and now we have it going up here in October. So from a month ago we were having about 300 new cases a day, and today we're having about 1,500, so that's 5 times as many. And we've likewise seen the same kind of change in hospitalizations. We've gone from a nadir of about 300 patients in the hospital and about 30 on ventilators to about 1,000 patients in the hospital and about 75 on ventilators. So New Jersey is 3% of the US population, but 9% of the cases in the United States, and we're 10th, but we're 3rd in number of deaths. Our first case was in May 4th. And as of this week, we have 228,000 cases. We have about 16,000 deaths, half of them in nursing homes. And then there is the illness in children, multi-system inflammatory syndrome in children. 47 cases in New Jersey, no deaths. In the United States, 1,000 cases and 20 deaths. And you can see that the mortality is far less than the general population. We've had a travel advisory in New Jersey for some time now in coordination with New York, Pennsylvania, and Connecticut. There's 41 states on the list now. It probably would have been simpler just list the states that are safe. Recently off the list is Hawaii and Virgin Islands. It applies to anyone from New Jersey going to other states. It's recommended, not required. And critical workers are excluded from that. How do you get on the list? You have to have 10 cases per 100,000 and a positive rate of 10% over a 7-day rolling average. And what's interesting is New Jersey's now reached that level. So we can't visit ourselves. So right now, new cases per 1,000 is 13.6 per 100,000. And North Dakota is the highest in the United States. They're having 105. We're having less than 20 deaths a day. And our spot positive test rate is 4.35%. The highest spot rate right now this week is Nebraska, 21%. Our numbers are probably underestimating the spot positivity rate because we're testing 50,000 asymptomatic nursing home workers every week. So that would artificially lower our test rate because the majority of those people are negative. Our R value, our RT value is 1.26, which is climbing. And I'm going to talk a little more about that in a minute. And as I mentioned before, we have hospitalizations of about 900 patients, and we have about 68 patients on ventilators. What's the R naught? These R numbers. R numbers is a calculation of how many patients get the virus from every patient we identify. We think that the R value for COVID in general is 2.5. So for every case you find, there are 2.5 other people who have the virus. The key thing is that you want your R value to be under 1. For most of the summer, New Jersey was under 1. If it's under 1, the virus will go away. If it's at 1, it's at a plateau. And if it's above 1, the virus is spreading and increasing. So let's talk about, someone asked a question about how effective is the virus. Okay, and this is some R values for some other viruses. So for hepatitis C, the R value is about 2. So for every case we identify, we found 2 people. Ebola is about the same. We mentioned that SARS-2 or COVID is 2.5. HIV is 4. SARS on this slide, this is SARS-1, had a ratio of 4. Mumps is 10, and measles is 18. So you can see how much more contagious it is. And the other interesting thing is, as you move to the right on this slide, you're looking at diseases that are very much transmitted by aerosol as opposed to particulate or droplet. So here's just a slide that shows you how our R value has been changing in New Jersey. Back in March, when we first had cases, our R value was 5.3. So for every case we found, there were 5 more cases that were there. By April, with the shutdown of the state, that transmission rate was markedly diminished. And you can see now in the last month, the R value has creeped up above 1. And that just means we're going to have more cases. Okay, we're still trying to learn a lot about what having COVID means. It may just be a 1 or 2 week illness. It could be asymptomatic, but we've had usually patients who are on a ventilator, usually on a ventilator for 20 to 25 days. And oftentimes they are very prolonged recovery. The CDC did some surveys looking at this and found that only a small percentage of patients had returned to baseline at 2 to 3 weeks. Will there be permanent lung damage in patients who have been sick? We're not sure. There is some probable vascular complications related to that because people are hypercoagulable or have more clotting. And so I've had many patients talk about having brain fog or fuzziness or feeling buzzy in their skin. And many patients have had this, I would say about 25% of the patients I see have some form of sequela that's long lasting if they were sick enough to be hospitalized. Okay, the age distribution, and this is early studies, really points to how severe the disease is in elderly, because age distribution is depending on people we tested and people we recognize. So this is not really talking about age distribution of people who are asymptomatic. This is age distribution of people who are ill. And you can see it's highly concentrated over the age of 60. If you look at people over 65, if those are the people who have died, men are much more at risk than women. And people who are over the age of 80 have a much higher risk of mortality than people who are under 50 or even under 40. When you look at mortality, in the United States, about 2 million people over the age of 65 die each year. And so you can understand the impact of 225,000, most of them in that age group. So about 1/10 of the deaths in the people over 65 are going to be from COVID. And if you are sick enough to go on a ventilator from COVID, your mortality is about 60%. What are the comorbidities? When we talk about comorbidities, we're talking about heart disease, cardiovascular disease, diabetes, chronic lung disease, COPD, chronic renal disease on dialysis, immunocompromised people with chemotherapy. And hospitalizations are 6 times higher if you have a comorbidity, and deaths are 12 times higher. Okay, that's as in contradiction to the mortality of the flu, which is about 0.1%. Obesity is also a high risk factor for mortality. It's probably higher than all the diseases, and we've seen that, in young people. At one of our hospitals, they had 2 mortalities, 2 gentlemen who rode in the same ENT van, and one of them was only 29 years old, but weighed 400 pounds. And blood type O is protective. We're not sure why. Michelle, how are we doing for questioning?
We have one that was added in regard to social distancing. The 6 feet is for both individuals wearing masks, and the distance increases if one or both individuals are not wearing masks. Is this correct?
I think that probably a better way to think about it is if you want to keep your pants up, you wear a belt and suspenders. Okay, either one is going to do the job, but both of them together is the safest process. I think that personally, I think the mask is the most important thing, because one of the things that's very interesting about wearing a mask is if you wear a mask, other people stay away from you. And they've actually done some studies using your cell phones to determine that people who wear masks, other people keep a wider distance from them. But you really want to be applying both. And if you don't want your pants to fall down, wear a belt and suspenders. So, and then I think we covered the risk of comparative contagiousness compared to other viruses and diseases.
Yep, they were the 2 that were in the chat room for now.
Okay.
Thanks.
So let's talk about disparate impact. Hispanics and African Americans are 3 times as likely to get infected and 2 times as likely to die from COVID. If you look at different races, and compare their percent of population, Hispanic, Black, and American Indian, all those groups have an increased impact from the disease. And part of that is probably because they have more comorbidities. So they have more diabetes, more high blood pressure, and more obesity. And it's also more likely because they're in a lower socioeconomic group, that they're less likely to have a job they can do from home. So they will not be able to access that. So they have to go to work, and they have a greater exposure in the workplace because of that. In many places in New Jersey, there was a lot of spread in distribution centers, warehouses, factories, and settings where people work close together. And also, these minority groups have poor access to healthcare in general. But one interesting thing is that Hispanics actually have a higher longevity or lifespan than the white population. We're not sure why. Is there a gender effect? Not for flu. Most infectious diseases are more deadly in males than females. For COVID, that's more pronounced. There's a 60-40 ratio. And the possible reasons are not completely understood. May be related to estrogen, may be related to a second X chromosome, may be related to culture. Men smoke more than women, and men are less likely to seek medical attention or control their medical comorbidities as well as women. Having a real strong immune system isn't necessarily as a two-edged sword, because having a stronger immune system is one of the reasons why women have more autoimmune illness than men. Okay, how about pregnancy? Influenza in pregnancy is a leading cause of hospitalization for women and pneumonia, but COVID doesn't seem to be having that same kind of impact in pregnancy. There are still just small studies, but it seems to be not an increased risk factor to be pregnant and be exposed. Treatment options: we have antivirals, remdesivir, and it decreases symptoms by 4 days, from 15 days to 11 days, and monoclonal antibody. And those are both the medications that the president and Chris Christie got when they were recently hospitalized. Both those conditions, you need treatments, you need to be hospitalized. Anti-inflammatories, steroids, Decadron, dexamethasone, decreased the mortality by 33% in ventilator patients, so that's important for the cytokine storm. There's lots of other factors that are being considered: vitamin D, statin drugs, zinc, Pepsid, colchicine. Whenever we don't have a good treatment, there's always a proliferation of treatment options, but none of the treatments we have are game changers or automatic. Dr. Fauci's talked about this, and he thinks it's treatment of the disease is going to likely be like HIV, where you're going to need a treatment cocktail or multiple medications. And there are now some studies ongoing combining remdesivir, the antiviral drug, with other medications and treatments. So what treatments actually work? Great nursing care. Thank goodness we have all of you in place. Proning, that's laying on your stomach, because your oxygen is better absorbed when your lungs are in that position. Remdesivir and dexamethasone are the two medications we talked about before. And then being on anticoagulation, either prophylactic or full therapeutic. Having COVID increases clotting and increases your risk for that. So that's an important thing to consider. Okay, why don't we stop there for a minute and just see if there's any questions?
Actually, it'll go right into the future. Someone's asking, and this is your personal take, if a vaccine becomes available in December, would you personally take it?
I'm planning to take a vaccine, but I don't think I'll be the very first person. I'd like to see some data on comparisons of the virus. I think the most important thing is going to remain masks and social distancing. And I think it's going to take at least a year to get the vaccine rolled out. You know, I think I'm going to go into more of the details on that in the next part of our talk. But I plan to take it, but I don't think I'll be someone who takes it in the first 30 days.
And okay, that was it.
Okay, so let's talk about a couple of things that are important when you're thinking about a pandemic. I can't tell you how many times I've heard somebody refer to this term, due to an abundance of caution, we shall do this, or has spoken about what are the best practices. In the setting of a pandemic, an outbreak, it's what can you do, not what's optimal. Unfortunately, everybody wants to get this perfect and have no flaws in what we do, and that's simply not possible. No matter what we try to do, whatever strategy we come up with, the virus is just too good and too smart and too elusive, and it will mutate, and things will be different. So there's not a perfect way to manage this. And so I think we have to be more accepting about what's doable. So for example, we've had habits where you wear a mask and you discard it after one use. If we did that, we'd be out of masks already. And so we have to do other things to be safe and use common sense. And unfortunately, that's not always the driving force in some of the decisions that are made. Viral transmission protocols. The CDC has a recommendation that after someone's been ill, they can return to work 10 days later from an onset of symptoms, as long as their symptoms have improved and they had no fever without antipyretics. For severely ill patients, which I would define as anybody who had to go into the ICU, that isolation period is extended to 20 days. At many of the facilities that I go to, I've tried to make it simpler and just say, let's just wait 30 days from a critically ill patient who's been in ICU before we take them out of isolation. But that's arbitrary, and it has to be common sense in terms of how many beds are available, what the pressures are, what the environment is, what the family's like. And as I've watched us evolve, I do feel like the state health department has given more influence to the facilities to make some judgments and report on them, as long as they're willing to take responsibility. For exposures, the isolation period is 14 days, and that's because the incubation for the virus can be as long as 14 days. So what's extraordinary is that a patient can be ill with the virus and get back to work before somebody who got exposed to the virus. There is some efforts in the rest of the world to shorten that, because no one wants a 14-day holiday, but they're not scientifically sound. The incubation is 14 days. That's what it is. If you want to if you want to allow somebody to come back in 7 days, you're taking some risk. And hopefully, if you're making those choices, you have some rationale. In Europe, where they're trying to do that, the rationale is they don't feel like people are admitting to being ill and coming to work ill. And they feel like by shortening the isolation period to 7 days, more people will isolate early in their exposure risk period so that they will have less transmission. And that's a theory. We don't know if that's going to work or not, but that's the concept of why you might see people changing or suggesting something different. Okay, what is an exposure? The CDC recently changed this, and it's now 15 minutes within 6 feet over a 24-hour period. And that's their firm definition on that. They felt they were missing a lot of people who were in and out of care over the course of a day. That cumulatively was enough exposure to be within 6 feet for that block of time. Wear a mask or go to jail. There's nothing better than a mask. N95s are important for aerosol risk, but regular masks are probably effective for droplet spread. Overwhelmingly, the disease is spread by droplet spread. In theory, there can be some aerosol and spread beyond that, but that's not how people are getting the disease. Also, in theory, the virus can remain present on doorknobs, handles, and fomites, the term for objects. Technically, they can last for sometimes days on certain plastic products, but that's not how people are getting the disease. It's mostly from droplets, so that's how important masks are. Transmission of the virus. It's highly contagious. We're watching it mutate. It doesn't mutate as much as the flu virus, but it mutates enough that we can track different mutations. And we think that it's becoming more transmittable, but not more deadly. As I said, there's an argument about droplet versus airborne. And certainly airborne is important for aerosolized procedures. But the overwhelming majority is droplet. We have not been able to see a difference in outbreak in nursing home settings or hospital settings in places that have used regular masks versus N95 masks, which are for aerosolized exposure. However, there is some data coming out now that suggests that face masks and face protection, face shields, are important and can reduce the risk because part of your respiratory system is the conjunctiva mucosal surface of your eye, and that's an exposure risk area. And so they have been able to show that having your eyes exposed within 6 feet could be a risk. And I think you're going to see more and more pressure for face shields and goggles to be worn by healthcare workers. So that's more to come. Again, I mentioned fomites. Technically, the virus can persist, but we've not really seen a significant number of cases that are relatable to that. The role of asymptomatic or pre-symptomatic infections is probably huge in transmitted diseases. Maybe half of all cases are asymptomatic. And that's probably why we've seen so much spread of the disease in the last several months.
I have a few quick questions for you. Is there a difference between outdoors and indoors versus social distancing?
I think social distancing it's 6 feet is 6 feet. It's an arm span. I think the difference between indoors and outdoors is circulation and airflow. Okay, there have been some very elegant studies that have shown, for example, in restaurants, being downwind from the vent is very high risk, and it really has to do with close proximity, irregardless of whether you're indoor or outdoor. But outdoors, since there's more circulation and more breeze and more flow, there's decreased risk in that setting.
Is there a medical regimen that you would recommend to protect oneself from being infected with COVID-19?
I think that it's really normal, regular diet and nutrients. I don't think there, for a while people were thinking that you could take hydroxychloroquine and protect yourself. It really comes down to wearing a mask. I don't have this in our slide program, but I'll give you an example of how that might apply. I think flying is very safe. Okay. If I was going to fly, I would probably fly with an N95 mask on, and I would not eat or drink on the plane. If you keep that mask on for the entire trip, you're not going to get COVID. You're going to have a bigger risk when you sit down to have a meal with your family at the other destination than from the travel itself. So,
will you be commenting on the effectiveness of the different types of masks, blue surgical, cloth, and N95?
Okay, so let's cover that right now. N95 is a mask that's worn to protect from aerosol transmission. Okay, if you're wearing an N95, you need to be fit tested for that N95 to establish that being the case. Otherwise, it's the same as wearing a surgical mask. If you're wearing an N95 and your glasses fog up, it's not functioning as an N95. That's a leak and it's not working. Okay, so and human nature is what it is. Everybody wants the best and they want the most protective, but it's only the most protective if it's worn properly and it's making a complete seal. It would be hard to work an 8-hour day wearing an N95 properly sealing. Part of that is even just that most of them have 2 straps, so there should be one around your neck and one over the top of your head, and most people are not wearing them that way. I think that surgical masks are a barrier and cloth masks are a barrier. The finer the product, the more effective that barrier is. But basically, you're just trying to create a barrier. And so I think that there is not a big difference between a cloth mask and a surgical mask, but to the public perception, I think there is a difference. So I think that in a hospital setting and a nursing home setting, we should probably be wearing the surgical mask. If people want to wear a cloth mask over it because it's stylish, that's perfectly fine to wear both. But I think that's probably the way to play that out. I think also that our regulators and our surveyors often are very rigid and are not always easily convinced of common sense, and that's what they're probably going to want to see, a surgical mask.
So when using an N95 mask, for how long can the practitioner continue to use his or her assigned mask while performing patient care?
Well, the regulations and the stipulations from the makers is 5 hours. Okay, but again, we get back to what's doable and what's practical as opposed to what's perfect. For the most part, in April and May, what I would tell people is that you have to keep that mask and use it until it's visibly soiled or no longer works. The strap is snapped. I think that it's probably practical to think about issuing people an N95 for a week and replacing it if it gets damaged or soiled.
Do you believe it is necessary to place a patient referred from a hospital setting who has tested negative for COVID-19 twice into a 14-day quarantine when transferred to a nursing home?
I think that's probably overkill, but I think that it probably is in your favor because if that patient does end up with the virus, you're able to say present on admission. So I think that, unfortunately these days, a lot of our answers have to have a political and a public component as well as a scientific component. I think that the challenge for New Jersey is that we had so many nursing home deaths. It's such a hot button, hot topic. It's very emotional, and the regulators and the health department do not want to have another case of a death in a nursing home. We're going to have one, but nobody wants to be responsible and take the blame for doing something that allowed something to happen. I think that right now our nursing homes are the safest in the country. I recently was going through some risk factors for patients coming to the hospital, and I had to spend some time convincing the hospitals that the nursing homes are no longer a risk. I'm more worried about somebody who went out to a restaurant last night than I am about somebody who's coming to the hospital from a nursing home.
Some associates are complaining of irritation with surgical mask, breakouts, and blotchy skin. Is it safe to wear a cloth mask under the surgical mask in a healthcare environment?
Well, the recommendation would be to wear the surgical mask and the cloth mask over that. Again, to me, it comes back to the doable, and I would accept that, and I would make the argument to the health department about that being a reasonable workaround.
Is a KN95 mask better than a medical or cloth mask? I think you just answered that.
Yeah, probably not. And again, an N95 mask is the same as a regular mask if it's not fit tested and not sealed. Part of it is if you're wearing an N95 and it's not, you're not aware of breathing, it's probably not tight enough.
Switching gears a little bit, rooms in a nursing home that share a central AC or heating system, does the virus go from room to room?
Probably not. I mean, some of that is theoretical, but it's very interesting. You know, it's all about what the soundbite is. When you look at some of the studies about how they've looked at like how the virus is suspended in the air, the way they do those experiments are like totally impractical. You know, they take a drum with fans in it and they spin it at 1,000 RPMs and spray a water into the air. It's just unnatural processes that they use to demonstrate, oh, the virus went here. You know, I think that, you know, it's interesting when you look at families at home, the spread to family members is only about 1 out of 3 in families that are doing nothing, just living at home. So it's interesting about how it spreads, but it doesn't. It's a fire, but it's not a crazy wildfire that consumes everyone.
So what are your thoughts about placing any resident who went to the ER visit and returned within 24 hours on quarantine for 14 days, even though the rapid test and a PCR test is negative upon return?
I think that it's a quagmire of trying to create rules to get a perfect system. I think, and as we move along, I'm going to talk a little more about it. The number one thing we need is rapid point of care resulting of an antigen test. That's cost effective. That is really the game changer for near term. Vaccine is the game changer for 3 years from now. Today, the fastest way to get back to normal life is to have point of care, inexpensive point of care antigen testing wherever you go.
And then the last question for now, can you speak to immunity once someone has had it? I understand antibodies will be available. It sounds like that is the way that will go away, though. Is there more information available about immunity? And should someone be confident in a certain amount of immunity? If so, for how long?
Okay, so that goes back a little bit. The CDC feels that there's only immunity possibly for 3 months. I think that it's probably longer than that. If you think back a few slides back, we showed a slide that showed the other SARS viruses, and they have antibody that lasts for up to 2 years. Okay, so I think that there is some immunity. You know, I think that I've noticed in some of our worst hit nursing homes in April and May, I have not seen clinical cases in those sites. We've had a couple of odd patients have the virus detected on testing, but I haven't seen anybody ill in the nursing home since June. So I think that there is some immunity there. And I think right now we are seeing manifestations of immunity in many of the nursing homes that had large outbreaks at the beginning of this. So those places are safer, but the health department doesn't want to take any chances, and they do not accept any of that theory or hypothesis for care because they don't want to be blamed. But I think that those places are very safe now, and we're not going to see cases and outbreaks in those settings for at least another 6 months. We still don't know, since this virus has only been first identified in January. We don't know how long antibody might last, and we don't know which is the right antibody. And I'm going to talk a little more about that when we talk a little more about the vaccines. Okay, so this is just a little more about transmission of viruses, very timely of what we're talking about. And again, and it's all you've experienced, having a positive PCR weeks after infection does not mean they're infectious. They have just fragments of the DNA present over a long period of time. I'm going to probably go a little bit quicker through some of these slides. These are sort of background, and like this is the data behind some of the comments I'm making that we can go into more detail as we go along here. So this is a study that looked at shedding, and really what was what we've established is that for the most part, if somebody's ill, it's not infectious beyond 8 days. They do not transmit the disease. Will wearing masks stop transmission? MMWR, these are studies that looked at the use of masks, exposures, where they had workers in a hair salon that were positive. They wore masks, and they followed those people who came to that site for a month. Many of them had tests, and there was no exposures. Here's a wash. This is from 1918, football team playing with masks before they wore helmets. Sports teams do not spread the disease during competition. Almost all the cases where sports teams have had outbreaks are related to sharing meals. It's all about when the mask is not on. Law of unintended consequences. School closed, parents at home can't work, domestic violence, alcohol, drug abuse. Alcohol consumption is up 25 to 30%, except for Corona beer. Why is Corona beer down? Because the owners shut down their factories to stop spread. So it's not available. Public's afraid to come to the hospital. The number of people who are dead on arrival on the paramedic squads is about 4 times what it was a year ago. That's improving, but during the middle of COVID, it was tragic how many people would just delay their care at home. And immunization rates are down significantly because people are not coming to see their doctors. If cases continue, what do we need to do? Avoid communal events where people are not wearing masks. Indoors is riskier than outdoors, and high-risk events, bars, indoor restaurants, weddings, indoor parties, barbecues, funerals, and choirs and church services. Okay, this is a slide that the Texas Medical Association put out, and you can see that opening the mail is the lowest risk that they have on there, and the highest risk is going to a bar. And various things are listed there. A backyard barbecue. Much of it is all about socialization and eating and not having the mask in place. Is herd immunity possible? Well, herd immunity is only going to be possible if the vaccine has a good take and it keeps people immune. Part of it is where are we in herd immunity? Some of the data, New York City, probably 20% of the population has been already exposed. There was one study that in Queens where 70% of the people they met in Queens were positive with antibodies. These were done by antibody tests. And you can see even in Wuhan, where the virus was first identified, only about 10% of the patients, the 10% of the people who live there have evidence of having the virus. We probably need to be at 60% for herd immunity, and we'd have to stay at 60%. So it depends on how long the antibody lasts. To maintain it, potentially to maintain immunity, you'd have to get a yearly vaccination to boost that immunity. When will we get a vaccine? Well, we only have a few days in October, so I don't think it'll be October, but it's probably going to be before the end of the year. The fastest vaccine ever developed was for mumps, and it took 4 years. And most vaccines take many, many years to develop. And developing antibody doesn't mean that you have the right antibody to protect you from the whole disease. So what's going on with vaccines? Right now, there are 154 vaccines being studied. There are 36 in phase 1, 16 in phase 2, and 11 in phase 3. In the United States, there's none approved, but there's probably 6 on the cusp of being approved by the end of the year. Let's just talk about the 4 most common ones. 3 of them require 2 shots. The one from Johnson & Johnson is a single shot. They're different in many different ways in terms of what they target and what they work for. There's a large number of vaccines being given in Russia and in China, and we have very little information on those. In New Jersey, the 500,000 healthcare workers are the highest priority. As I mentioned, 3 of the 4 vaccines that are likely to be released require 2 injections. That's 81,000 vaccinations a day, 5 days a week for 6 months. So by the time you finish, you have to start vaccinating again. So I don't think herd immunity is going to save us. What have we learned from other countries? Isolation hard and early, New Zealand and Uruguay. It's worked pretty well. Again, the issue is having enough testing and being able and knowing what you're going to do with people who are testing. South Korea has done very well with contact tracing. New Jersey has 2,000 contact tracers. So the job of a contact tracer is to call the positive test and say, can you tell me who you've been in contact with the last 48 hours so that I can contact them? The most common answer is, no, I don't want to do that. I'll let them know. Okay, we're only getting about 40% of the contacts traced. So it's not that we don't have enough tracers. We just have a culture that doesn't want to share that information. Some groups have tried to identify high-risk groups and protect them. That hasn't worked. India tried to shut down early, but unfortunately, and again, getting back to some of our issues with low socioeconomic class and people who have to work, those people, there's not a model for them to be off for weeks at a time. Okay. Why are some areas having such small numbers like Thailand and Vietnam? Well, part of the advantage there is that that part of Asia accepts masks easily. They're younger, it's a younger population, less pre-existing conditions. They're not doing a lot of tests, and maybe there's something genetic. Australia, New Zealand, fines and issues like that, requiring anyone who arrives to be on lockdown in a hotel for 2 weeks, are not things that work in other parts of the world. You have to have some, Australia and New Zealand have an element of isolation because they're remote. Swedish experiment in common. One of the issues, and I'm just going to use this slide to talk about economy and why there's no toilet paper in the stores. Over the last 20 years, the world has worked towards just-in-time delivery. And so we no longer have warehouses and shelves of stuff waiting to be delivered. Many just-in-time deliveries, just-in-time inventory is the way the world has evolved. We don't have any reserves anymore. So that's why it's so easy to run out of PPE. How do we run out of masks? Why are we running out of gloves? Because we just don't have a factory full of them like we used to 20 years ago. And so the timing and the evolution of delivery of products has moved towards not having a lot of things in the chain of delivery. And I think that's a big factor why there's such a problem. We don't spend money. We should be spending money on healthcare the way we spend money on defense, because it's like a war, and we just have to be better prepared. And the challenge there is that you want to be in a situation where people say, you did too much. Okay, if we did too much, then nothing happened. And unfortunately, we're facing a condition now with this pandemic that we haven't done enough. We have gaps. We have shortages. We have things that we should have done better. So again, let's try to get back to like what's important. We need an inexpensive point-of-care antigen test, and that's the most important pathway, I think, to normal activity. We have to know who has the virus and who is infectious. Mask works and should be worn, and social distancing matters. Those are the four elements that I think are crucial. The vaccine is going to help, but that's not going to help today, and that's going to take. The challenge there is that we're trying to. Our goal is 60 to 70% of the population to be immunized. We've been trying to immunize people for the flu for decades, and our immunization for the flu is at about 50%. So we haven't even accomplished it with the flu. Now, maybe we're going to be more motivated because of the deadliness of this pandemic, but it's still a huge operational challenge to get these vaccines out and get everybody immunized. So future concepts. So I think that future nursing homes are going to be redesigned into more of a pod and smaller entity concept. I think that large congregate activities are going to be modified to maintain bubbles. So at some of the nursing homes I've spoken with, we've talked about creating small groupings that always eat together and stay together and function in a 6 to 12 person bubble to try to reduce not just this virus, but other viruses. I don't see how we're going to get away from testing in some form. And it's got to be less costly, and it's got to be point of care. And I think that masks are not going away. We're going to be wearing masks for a long time. Michelle, any questions?
I have two more in the box. When a resident tests positive for COVID but is asymptomatic, should they move the roommate immediately, even though he or she was exposed?
Yeah, I don't think the roommate, well, it depends on what beds are available. Okay, that roommate is a PUI. So the roommate, and it depends, again, as I said, available beds. If a patient turns positive, they should be moved to your COVID unit or declared COVID at a COVID site. The roommate can be moved, but they have to be managed as a PUI. And so they need a 14-day quarantine from their last contact. So potentially, they could go into your 14-day observation corridor and be in their room.
And then earlier you stated blood type O is resistant. Are you saying they cannot get it?
No, it's blood type O is safer, less severe. They still get it, but they're less severe. They're less likely to be on a ventilator. And remember, back in April, 1 out of 4, 1 out of 3 patients was on a ventilator. Now it's less than 1 out of 10. So that's age, and we're better taking care of these patients, and it's less severe.
Our final comment in the chat is from Jim Gonzalez, and he states, as chairman of HCANJ, I wanted to thank you, Dr. McManus, for the most informative and practical presentation on the impact of COVID-19 that I have ever heard since the beginning of the pandemic. Thank you for your commitment to sharing your knowledge and to us today.
Well, thanks very much. I enjoy working with all of you. I just put this on just for people to reflect on. This is one of the first little poems that I found from 1918, and it's timeless, as it says at the top, in terms of what's happened and what COVID has done for everybody, in terms of getting us at home and simplifying our lives in some ways. And we're going to recover and rebuild, but it's going to be a long process. So this is just something to read and reflect on. And thanks for your attention.